All right, welcome back. Our next lecture in our selective lecture series is going to be talking about tracheotomies. Again, I'm Julina Ongkasuwan. I am a laryngologist in the Department of Otolaryngology, Head and Neck Surgery. So we're actually going to start this one with a case. So we have a 75-year-old male who's had increasing voice problems over the last year, odynophagia, again, which is pain with swallowing, and now he has shortness of breath and noisy breathing over the last month. When you see him, he has stridor, inspiratory stridor. Stridor being a high-pitched noise which represents turbulent airflow through the larynx. So you do this flexible nasolaryngoscopy in the office, and you see this giant Goomba in his larynx. So, top of your differential. First thing on your differential should be a squamous cell carcinoma. That's the most common thing that we see in the larynx, causing large obstructing masses in an adult. In this particular case, because he has so much airway obstruction, most otolaryngologists would choose to perform an elective tracheotomy, followed by biopsy, staging with the chest x-ray CT of the neck to look for a lymph node metastasis, and then treatment for a large lesion like this, depending on the stage, might include laryngectomy versus chemo and radiation. But that is the topic for another lecture. Specifically, we're here to talk about the trach. So, a little bit of terminology. Do you know what the difference is between a tracheotomy and a tracheostomy? The surgery itself is a tracheotomy. Otomy meaning to put a hole in it. So you're doing a tracheotomy. Versus the tube itself that we place, which is the tracheostomy. Though in reality, we do use these terms largely interchangeably. Okay. So what is the difference between a tracheotomy and a cricothyroidotomy? So listen to the words. So again, otomy means put a hole in it. So tracheotomy means we place a hole in the trachea. Typically, we do this between the second and third tracheal rings, in general. Okay, whereas a cricothyroidotomy is a hole placed between the cricoid cartilage and the thyroid cartilage in this cricothyroid membrane. The cricothyroidotomy is really a surgery meant for life-threatening, life-saving emergency only. Why would you choose to do a cricothyroidotomy over a tracheotomy? So you're in the OR, anesthesia induces, but they can't mask the patient, they can't intubate the patient, they can't place a tube, and the patient's desatting, they're about to die. That is the circumstance in which you do a cricothyroidotomy. Why? If you go ahead and feel your own neck, you can feel your thyroid cartilage. You can feel the thyroid notch. In males, the most prominent cartilage in the neck is going to be the thyroid notch. It's going to be your Adam's apple. Okay, so then you can march your fingers down to right under your thyroid cartilage and feel your cricothyroid membrane. In women, the most prominent airway cartilage is going to be your cricoid cartilage. So you feel your cricoid cartilage and go just above that, and that's going to be your cricothyroid membrane. So there's nothing overlying the membrane. It's just skin. If you look on this model here, thyroid notch, thyroid, cricoid, see there's really nothing between here. So you can get into this airway very easily in an emergency. Where we would normally place our tube, a tracheotomy, you can see there's this large vascular structure that sits right over this area, and that's the thyroid gland. And you're in a big rush. You don't want to get into a bunch of bleeding through the thyroid gland. Okay, so in the circumstance in which you cannot put an airway, any type of airway in, whether it be an endotracheal tube or a laryngeal mask airway into the patient, or you cannot mask the patient, that is the indication for a cricothyroidotomy. And once you put the tube in and you save the patient's life, hooray, everyone's very happy. You then have to take the patient to the OR and revise it to a formal tracheotomy and get this tube out of that cricothyroid membrane. Because if you leave a tube here, you put the patient at risk for developing subglottic stenosis because you have a tube sitting in the cricoid ring, right? Because you put it in the cricothyroid membrane, the tube's going to point down through your cricoid ring. And you have a tube sitting just below the vocal folds, and that's going to put the patient also at risk for laryngeal stenosis. Those are really bad problems and very hard to fix. So once you've saved their life with a cricothyroidotomy, you then have to revise it to a trach. Okay? So, what are the indications for a tracheotomy? One of the most common reasons that we do tracheotomy is prolonged intubation. And in adults, we define prolonged intubation as 2 weeks of intubation. The big reason why is, again, when you are orotracheally intubated, you got a breathing tube in your mouth, passing through your larynx into your trachea, you've got a big plastic tube sitting between the vocal folds. And over time, that's going to cause inflammation and erosion of both the true vocal folds as well as the subglottis, the area right beneath the vocal folds. And again, that puts patients at high risk for subglottic stenosis and laryngeal stenosis, which are, again, very difficult problems for us to fix. So you try to avoid having those problems altogether by tracheing those patients if you think they're going to have to be intubated for more than 2 weeks. Airway obstruction, like our case presentation where you have a large obstructing tumor, is another reason for a tracheotomy, or a patient who has subglottic stenosis or laryngeal stenosis, and you're trying to bypass this obstruction, is a reason for a tracheotomy. Edema, neoplasms, trauma can be causes. Is chronic aspiration a reason for tracheotomy? The answer is no. Even if you place a cuffed tube, this is a picture of a cuffed tracheotomy tube, does not prevent aspiration, despite what you might hear. The patients may still aspirate, food is still going to get into the airway, it just accumulates above this cuff, and eventually they're still going to aspirate. The only advantage a trach provides for a patient who aspirates is that now you have better access to their lungs because you can stick a suction tube into the tracheotomy and suction out their lungs. So you get better pulmonary toilet, but the trach itself does not prevent aspiration. So we'll show you a trach so you know the different pieces of it. Okay. This is a Shiley tracheotomy tube. Shileys just happen to be the most common in the hospitals here and around Houston. The different parts of the trach. So this piece is called the outer cannula. Okay, you can see this particular trach is a cuffed trach. It's got a cuff here, which is attached to this balloon on the outside. This is called a pilot balloon. So if you take a syringe and inflate this balloon, it's going to inflate this cuff, all right? Do you know what the purpose of the cuff on a trach or an endotracheal or an endotracheal tube is for? The purpose of the cuff is to create a seal. So when you have a patient who's being ventilated, they are on positive pressure ventilation. You're blowing air into their lungs. The air from your ventilator is going to want to take the path of least resistance, which in general is going to be back out through the mouth or through your trachostoma. So what you do is you inflate your cuff to help create a seal with the trachea to prevent the air leak back out your mouth. That's what the purpose of the cuff is for. People often ask, how much air do you need to put in the cuff of your endotracheal tube or your trach? You have to remember the purpose of the cuff is to create a seal to prevent an air leak. So how much air do you need to put in there? Just enough so you eliminate the air leak. It's going to be dependent on the size tube you place relative to the diameter of the trachea, and it's also going to depend on the chest wall and pulmonary compliance of that individual patient. There's no set volume for how much air you place in here because there are a lot of variables per each individual patient. At any rate, cuff trach is really indicated only for patients who are actively being ventilated. Okay, so again, this is called the outer cannula. This is an inner cannula, all right? And this is known as an obturator. So the obturator is primarily used when placing a trach. You can see it goes into the outer cannula and it helps smooth out this tip region to make it easier to place the trach. Placing the trach is pretty simple. Patients can do this for themselves. Families do it for our pediatric patients. For a well-matured stoma, an old trach, it's a little bit like placing an ear piercing. Place it directly in the low neck. If you go directly in like this, sometimes you'll hit a big chest, so it can be a little bit difficult. So if you go 90 degrees in the hole, get the patient's neck in extension, usually with a shoulder roll, and you can just follow the curve and the trach should slide right in. Okay. And then once you get the trach in, you take out the obturator and you place this inner cannula into the trach, into the outer cannula, and lock it in place. These dual cannula trachs with an inner and outer cannula, it just makes it a lot easier for the patients to clean it because all these trachs tend to get full of mucus and debris. They just take it out, they unlock it, pull it out, and they can use pipe cleaner to clean this out or use a disposable inner cannula to put a fresh one in. Okay. What is the difference between a laryngectomy stoma and a tracheostomy stoma? Okay. What is a laryngectomy? If you listen to the word, ectomy means to take it out. So laryngectomy means we remove the larynx. So when you perform a trach, really all you are doing is putting a hole in the trachea and putting the tube in to hold it open. Okay? A laryngectomy, you actually remove the entire larynx. As you can see in this diagram, you take out the entire larynx and you divert the trachea. You sew the trachea directly to the skin. So your trachea is no longer communicating with your nose and mouth. These patients are also known as obligate neck breathers. Okay? They cannot breathe through their nose and mouth. All right? If you choose to intubate a patient who has a laryngectomy from above, from their mouth, the tube will only go in the esophagus and they will die. So these patients will only be able to breathe through their neck. When you sew the trachea directly to the neck, oftentimes the cartilaginous rings of the trachea will hold that stoma open, so they may not have to wear any appliance in their neck, and they may be able to just sit with their neck open. So sometimes it's an important question to ask. Is this a laryngectomy stoma or is it a tracheostomy stoma? Because again, a tracheostomy, if the trach becomes dislodged and you can't replace it or becomes obstructed, in a pinch, you can sometimes, depending on the reason for which they were trached, intubate them from above if you can't get a trach back in their stoma, but meaning that you can intubate them by mouth. However, a laryngectomy patient, you cannot do this because if you put a tube in their mouth, it will only go into their esophagus. Okay. Oops. So, how do you talk with a trach? So, there are adapters that you can place on the end of a trach, either a cap or a valve that you place on the end of the trach. So with a valve, the valve opens when they breathe, so they breathe in through the trach. When they exhale, the valve will close, so the air then passes around the trach, back up through the larynx, and they can talk with their own larynx, so it sounds like their voice, okay, with a speaking valve. In addition, with a cap, you can just put a cap over the trach, and then they're breathing through their nose and mouth like you and I, okay, and they're talking with their larynx as well. For a laryngectomy patient, however, if you want to rehabilitate voice and speech, you have to find a different type of vibrator. Remember, the larynx is just a vibrator, okay? But you have to find some other sound source. So different options include an electrolarynx, which is that mechanical sound. It's usually a gray contraption that they put up next to their skin or their mouth, and it's really just a diaphragm that vibrates, causes their pharynx to vibrate, and they shape that vibration sound into words. Another way they can rehab speech is they can learn esophageal speech, which is a little bit like burp speech. The patients swallow a bunch of air and they gradually burp it out, which allows the pharynx to vibrate, and again, it generates speech. They then can shape that sound into speech. Finally, the last way is called a tracheoesophageal puncture, where we surgically make a hole between the trachea and the esophagus and place a little prosthesis through here, a little piece of plastic tube through here. Patient inhales, and then on exhalation, they cover their stoma. The air is passed through the little tube we placed here, passes up through the pharynx, which then vibrates, and again, they shape that vibration into speech using their tongue, palate, and pharynx. So that's how you rehabilitate speech with a laryngectomy. Okay. All right, and that's the end. If you have any other questions, please feel free to email me at julinao@bcm.edu. Thanks.